colleagues and audience members. We've had a very interesting and packed first session, and we're sort of into the second half now of the Patient Day, part of the Global Heart Valve Disease Awareness Week, which has been organised principally by the charity Heart Valve Voice, whose principal aim is to raise awareness of heart valve disease. And Will, the Chief Executive of Heart Valve Voice, is now going to introduce our next speaker, Dr. Chris Arden. Thank you.
Yeah, welcome everybody. I hope we feel a little bit more refreshed. Cups of tea on the desk. Sorry, a lot of the Facebook Live community saw me eating my flapjack. Welcome back everybody. Just a bit of kind of an update for anyone new to the session. We had a breakfast welcome this morning with Dr. Huon Gray, Roger Black and Chris Young, our chairman, who just talked about setting the scene of what heart valve disease is, the challenges that we face and what we're trying to do to remedy some of those challenges. We then heard from Dr. Ben Onshar, who put a spotlight on heart valve disease and went through the kind of epidemiology of the disease. And then we saw some live diagnostics. Those live diagnostics were really useful to see because over the past couple of months, patients might feel a little bit rude not being able to get into clinics as much and having virtual appointments. So Dr. Dave Smith gave a review of some of the resources that can help you in virtual appointments. Now it's a pleasure to welcome Dr. Chris Arden. He's a general practitioner with a special interest in cardiovascular disease. Chris is also one of our trustees at the charity. So I'm glad it's going well, that one of my bosses is watching and things seems to be going well. We've had lots of people on Twitter and Facebook participating, and we've got a healthy number of people here in the room with us today. Chris, I just wondered if you could also give us a little bit of a background to our audience of your involvement with the Primary Care Journal, some of your experiences of working with valve disease patients, and then into your presentation, which is all around the valve disease pathway, primarily from a GP onwards.
Great, thanks very much indeed, Will, and for the invitation to participate in today. My name is Dr. Chris Arden, sort of first and foremost a GP just outside Winchester in Hampshire, but also got a special interest in cardiovascular disease, and obviously an important part of that is valvular heart disease. I'm also involved with the Primary Care Cardiovascular Journal, and we're very interested and keen to try and share sort of our knowledge and experience with colleagues in primary care. What I'm going to sort of focus on today is to try and see and describe the important role that we've got as general practitioners and my nursing and sort of pharmacy colleagues in the community in terms of trying to identify patients with valvular heart disease, what we should be looking out for, and also interventions that are important in primary care in terms of investigating patients to make sure that they receive the most appropriate treatment and intervention if that's appropriate. A lot of my talk will be based on the gold standard framework in terms of valvular heart disease. So looking at the sort of pathway, obviously primarily in primary care, looking at sort of case finding and initial referrals, how we can get patients appropriately investigated, looking at assessment and diagnosis, obviously covering areas around treatment as and when that's appropriate, as understandably patients often have questions about not only the investigations they've had, but also potential treatments or interventions that they may require. And very importantly, providing support for our patients post-intervention as and when appropriate. Very, very happy to take questions probably at the end of the meeting, if that's okay, just to make sure that we keep up with the flow of the meeting. With regards to our role in primary care, the most important thing is just having a threshold and an index of suspicion that patients, the symptoms they may be presenting with are related to valvular heart disease. Patients often experience and present with a variety of different symptoms, to us in primary care. And a lot of those may or may not be related to heart disease, but it's very, very important that we keep that sort of index of suspicion at the foremost when we're assessing our patients, particularly sort of red flag symptoms. So if patients are experiencing new onset chest pain or tightness or angina type symptoms, getting dizziness or blackouts, reduced stamina or exercise tolerance, and breathlessness, we need to be mindful that some of these symptoms may well be at least wholly or in part related to underlying valvular heart disease. This is particularly the case in patients in whom the probability of them having valvular heart disease may be higher. So patients who are more elderly, above 65, for example, or those with a family history of valvular heart disease. And the one that comes to mind is obviously bicuspid aortic valve. Those patients will tend to develop valvular heart disease, particularly obviously aortic valve disease earlier on in life. So we need to be mindful of patients that may be in a higher risk category. Patients who are symptomatic that we detect a murmur on, and again, I'll come on to that in a second in terms of how we examine and detect murmurs. If they're symptomatic, we should be managing these as a high risk cohort of patients, and akin to our pathways around cancer diagnosis, we should be looking to refer patients ideally within 2 weeks to see a specialist cardiologist, ideally with an interest in cardiovascular disease, but a general cardiologist will have all the expertise in terms of appropriate investigation for these patients. If they're asymptomatic and we're picking up a murmur incidentally, then again, we should be referring for further assessment, ideally within 6 weeks. A lot of us in primary care are fortunate enough to have access to direct access echocardiography. So for some of us, that's an option in terms of investigations, but if not, referral to a cardiology sort of specialist in an outpatient setting is appropriate. Most importantly, again, we need to communicate our findings with the patient so they are aware of what investigations are going to be undertaken and what the next steps in terms of their pathway and management. Clinical examination and auscultation is absolutely key, and obviously I'm conscious and aware of the pressures on both GPs, nursing and colleagues and pharmacists in the community setting, and sometimes time can be a factor, but it's very, very important that any patient who's presenting with symptoms which may be possibly related to cardiac or cardiac valve disease does have a thorough investigation, and the most important of that is auscultation. Clinical examination, particularly auscultation, is the first step towards the diagnosis of valvular heart disease and the assessment of its severity, always bearing in mind that even a faint cardiac murmur may be associated with relevant valvular disease, especially where there's already cardiac impairment or heart failure. The murmurs that we're most concerned with are obviously those related to the left side of the heart, which is really the main workhorse and engine of the heart, where you tend to have a higher pressure system, so more stress across the valves. So they tend to develop more significant valvular lesions, which will present with symptoms, as I mentioned, primarily sometimes breathlessness or fatigue. So murmurs that we're most interested in, particularly sort of systolic murmurs. So during that phase where the heart is contracting and pushing blood out of the heart. So aortic stenosis is a typically systolic type murmur, as is mitral regurgitation. Diastolic murmurs, again, that we're interested in on the left side of the heart, are aortic regurgitation or mitral stenosis. These are the sort of typical heart sounds. Hopefully they'll come through okay on your sort of audio. We have a normal heart sound, and then the typical sound with aortic stenosis. And mitral regurgitation. And pulmonary stenosis. And tricuspid regurgitation. So again, all of us in primary care, whether it's GP or sort of nursing, should be familiar with the normal examination and the precordial sort of chest examination, and make sure that we're able to sort of pick up murmurs, whether they're symptomatic or sort of asymptomatic. We know, just referring now to aortic stenosis, we know symptoms are particularly important in patients who have known aortic stenosis, because we know this has an important bearing in terms of their quality of life, both in respect of symptoms, but even more importantly in terms of increased mortality and death, particularly when patients develop symptoms. So there can be a long period in aortic stenosis where the patient is relatively asymptomatic and carrying out their normal activities of daily living with relatively little in the way of symptoms. Once they develop symptoms, whether that's angina, so chest pain or tightness, whether it's dizziness, so syncope is sudden blackouts, or heart failure, so they're getting fatigue, reduced exercise tolerance, and breathlessness, we know that the prognosis in that setting is very, very poor indeed. So again, it's just we need to be very, very mindful in primary care and the community in assessing our patients who have either known or suspected aortic stenosis. Once they develop symptoms, again, we need to be managing this as a matter of urgency in terms of referring them on to our specialist colleagues in secondary and tertiary care. Approximately 50% of untreated patients with severe aortic stenosis will die within 2 years of experiencing symptoms. So this is akin and aligns with all the issues we have around sort of managing the worst sort of cancer diagnoses. So we need to be managing it in exactly the same sort of framework and with the same urgency and attention. In terms of assessment and diagnosis, echocardiography is key, so ultrasound examination of the heart in any patients with a murmur, whether they're symptomatic or asymptomatic. Fortunately, the vast majority of GPs now have access to the echocardiography directly. In a few areas, we're still having to do that through our cardiology colleagues through the hospital, but whichever system each locality has, it's important that the conversation is had with the patient and the investigation is offered, and echocardiography is investigation of choice. Communication, surveillance, and potentially deferral is a decision that will then be made by the cardiologist or in the specialist valve clinic. So in terms of referral, we need to refer patients again as a matter of urgency if they've got symptoms. In the valve clinic, a cardiologist with or without specialist interest in valve disease will take on the appropriate investigations. Often that will include transthoracic echocardiography. In some situations, they may need to do further investigations, including transesophageal echo or other imaging, or even angiography to assess the valvular lesion in more detail. But again, importantly, that'll be done within the secondary and specialist sort of setting. Communication, as always, is absolutely key with the patient, their next of kin and relatives, so they're fully informed as to what the investigation will involve, the implications of the investigations in terms of potential findings, and what bearing that will have in terms of sort of management decisions. The heart team is now key in terms of how we sort of assess patients in the secondary and the sort of tertiary care setting. So again, just in this situation, referring to aortic stenosis, the diagnosis is confirmed within the hospital setting. The referral is then made to the heart team for patients with severe aortic stenosis, again, whether or not they have symptoms, for the heart team to then have a multidisciplinary team approach to applying the latest evidence, consensus, and guidelines, and then making sure that a management plan is formulated for the patient. And again, that is communicated to the patient, their relatives and next of kin as appropriate. In terms of treatment options, so again, this is very much within the sort of secondary care, sort of hospital setting. Obviously, there's options in terms of surgery or transcatheter approaches if you're looking at aortic stenosis in terms of valve replacement. One option may be deferral, so no intervention is actually appropriate at that point in time, but it's very important that a clear plan is made and articulated and communicated with the patient so they know what the interval for review and surveillance should be. At the very, very least, that should probably be annual. In certain situations, it's deemed appropriate that intervention is not in the best interests of the patients. The risks are simply too great in terms of either transcatheter or conventional surgical intervention, and in which case we need to be seeing how we can support the patient and their next of kin and family in terms of managing symptoms that might arise out of their valve disease that need other tailored approaches, looking at medication and other ways that we can alleviate symptoms if intervention is not appropriate. And that sort of more palliative approach, again, is very, very important, and communication is going to be absolutely key. In terms of sort of following up patients, certainly patients with mild valvular lesions, whether it's mitral valve or aortic valve, occasionally tricuspid valves, should ideally be having echocardiograms at least every 3 years. Again, that may well be within the hospital setting with cardiology follow-up. In certain situations, it may be within a community sort of cardiac sort of clinics. Those patients with moderate valvular lesions should at the very least have annual review in a specialist valve cardiology clinic. And again, if there's any change in symptoms, that needs to be factored in terms of management planning for that individual patient, and that'll be undertaken by the cardiologist. Patients with severe lesions who aren't deemed timing-wise to be appropriate for intervention should be having review at least every 6 months, again, within the setting of a specialist cardiology clinic or a valve clinic. So again, the framework is there in terms of what we should be delivering and offering our patients and the expectation that they should have in terms of managing their ongoing care. We've got very, very good evidence now in terms of how we should be managing patients. Again, I'm referring here to aortic valve disease and aortic stenosis. We've got other interventions for those patients who do need aortic valve replacement, and obviously transcatheter valve replacement has become quite standard procedure now in the UK and Europe, and the guidelines now is suggesting that there's a role for transcatheter valve replacements, even in a lower risk group, so an intermediate risk group, whereas historically, and that's its inception, it was primarily reserved for sort of high risk patients who are deemed too high risk for conventional surgery. But we're seeing the evidence base developing and that moving into lower intermediate risk groups. Post-treatment management, so patients who've had intervention for their valve lesions, again, it's very, very important they get appropriate support, both in a hospital setting, whether that's through cardiac rehab, or through the community in terms of their sort of longer term follow-up. It's very important that ongoing risk factors are managed appropriately. So a lot of patients will have associated comorbidities, so other illnesses such as high blood pressure, coronary vascular disease. So that needs to be managed appropriately. So they need to have regular review in a community setting, making sure that their blood pressure is well controlled and other lifestyle factors are optimized. So just coming back to sort of basic principles in terms of our role in the community, it certainly is to be aware, to listen, to look out for those symptoms that patients are presenting with, and just have at the back of our mind, could this be cardiac? Could this be related to valvular heart disease? So the history, as always, is very, very important in terms of the initial assessment. Obviously, we follow that up with examination, and the key part of that is auscultation. We have to have a high index of suspicion, particularly in the higher risk group, so more elderly patients or those with a past history of a murmur or bicuspid aortic valves, that this could be a progression of their aortic valve disease. So we need to suspect valve disease. And we certainly need to be referring patients on for further assessment. rapidly if they've got symptoms, and in a more timely fashion if they're genuinely asymptomatic, to assessment with our cardiology colleagues in secondary care, and ideally through a heart valve clinic. So in summary, heart valve disease, certainly we're seeing a lot more of it, primarily driven by demographics, obviously an aging population, and the greatest cause or underlying reason for valvular heart disease is just anno domini, it's the passage of time and degenerative function in the valve. So we're certainly seeing a lot more of it, so we do need to be aware of it in terms of symptoms that may be associated with it, particularly reduced quality of life, reduced stamina, exercise tolerance, a lot of symptoms which patients may just attribute to a natural aging process without actually being aware there are conditions that are contributing to their symptoms which are amenable to intervention and treatment. Auscultation is absolutely critical as part of the initial assessment, so all patients should have a thorough cardiorespiratory examination, and listening for the heart sounds is a key part of that. Patients who have a murmur or suspected murmur with symptoms should also be referred initially, certainly for echocardiography if they've got access to that, or directly through to the cardiology in secondary care. So refer patients for further assessment to the heart team, and we know that interventions are very, very helpful, not only for symptoms and quality of life, but also for prognosis, so reducing the risk of mortality, particularly around aortic valve disease and aortic stenosis. So thanks very much for your attention. I think that's my last slide. I'm very happy to take any questions. Hopefully may have some answers as well, but if you do have any questions, very happy to take them while I'm here. Thanks very much. Thank you.
Thanks, Chris. Yeah, there are a couple of questions coming through the Facebook viewers at the minute, and one from Twitter. The question is, when do I call the valve clinic, or when do I call my GP if I'm concerned about either the symptoms or their care pathway? So if they're under a valve clinic, when is it that you should speak to the clinic, or when to the GP? And what role does the GP have once you are at the clinic, and treatment and afterwards? So we've got a couple of minutes. If we can capture those two, it'd be useful.
Yeah, I think any change in symptoms that you would consider normal for you, so any change from sort of baseline, particularly around sort of breathlessness, the red flags that we would look for, again, if we're looking at sort of aortic stenosis, are sort of breathlessness, new onset chest pain, tightness or discomfort, which may be akin to a sort of angina. Certainly any dizziness, blackouts, what we call syncope. And reduced, exercise tolerance, fatigue, those sort of symptoms. So I think if you're finding that you're able to do less, you're having to rest more, certainly any signs of what we would describe as heart failure, so you're getting impaired pumping action of the heart. So if you're feeling a bit congested or getting symptoms of sort of fluid retention, that could be a sign that the left ventricle is struggling in terms of maintaining a cardiac output. So any symptoms like that, sort of puffiness of the ankles, particularly getting breathless or breathless at night, all these. So if there's sort of significant change from your baseline, certainly you should be letting us know in primary care. And obviously if we're concerned, again, we would certainly share that with colleagues in sort of secondary or sort of tertiary care. Again, some of these symptoms can be managed in the short term medically, certainly with congestion, and sometimes diuretics can play a role if there's signs of impaired heart function. So there's little things we can do in a community setting in terms of helping with the symptoms. But if it's due to progression of the valvular disease, definitive treatment is going to be by management and correction of that valve abnormality. Everything else is essentially just managing the symptoms around that. So you have to manage the underlying problem.
Another question that
certainly do see your GP, practice nurse, potentially it may be the cardiac rehab team. Just keep in contact with them. And I think use them as your advocate if you're having difficulty obviously getting through to the hospital. And I know things have been very, very difficult for a few months now, and obviously in terms of where we are at the moment, but all the lines of communication are still open, so we can contact directly, you know, link in with the cardiologist or the valve clinic. So if you're having difficulty getting through, then do let us know in primary care, and again we'll do our best to try and help support you and make sure those links are still in place.
The final question before we get the start the patient section is around endocarditis, Chris. It often presents first in primary care. I wondered, we've got 3 minutes, whether you could do an endocarditis presentation and explanation in 3 minutes. Perhaps not, but we've just done a campaign on that on the website. But yeah, go for it, please.
No, very good point. No, thanks for raising that, Will. And again, I should have sort of touched on that at the end, but really, really important that we remain vigilant around the increased risk of infection, both pre-operatively in terms of the native valve, just due to the sort of disruption in blood flow and the turbulence around the valve. These patients are certainly at much higher risk of getting infection of the heart valve. And again, if they've had replacement valve, again, the last thing we want to see is that valve getting infected, because that's very, very difficult to treat. And obviously, if they need further intervention or surgery, that's significantly higher risk. So all of us, whether it's primary, secondary care, need to be very, very vigilant for any symptoms that patients present with, which may be related to underlying infection. And again, there may be fairly soft symptoms initially, fevers, sweats, swinging fevers, which can go on for a period of time, just feeling generally unwell, just sort of lousy, rundown, fatigue. Examination wise, certainly they may well have a fever at the time that we examine them. Again, the murmur may well be quite pronounced. So again, auscultation is a key part of that examination. Again, it's about having an index of suspicion. We know this patient has valvular heart disease or had a previous valve replacement. We need to be thinking about endocarditis. It's not something that you want to miss. In terms of investigation wise, again, if we have a high index of suspicion, then we should be referring patients in for that to have formal assessment, blood cultures and investigations in hospital. Very, very occasionally, we might do blood tests to check for inflammatory markers in a community setting if we're not quite sure and it doesn't all tie together. But no, absolutely, Will. It's a really important topic, and it's one that we need to be mindful. And patients, likewise, again, I'm sure, hopefully they're given advice following their surgery that these are things to look out for. So again, if you're concerned as a patient that this might be, then again, mention it to your doctor, and hopefully investigations will lead on from that. But yeah, but it's a very, very important area. Yeah.
Thank you, Chris. Wonderful session there. Thank you for putting us through our paces on the patient pathway.